speed. Right, so if you have read and understood, considering it history-taking station, kindly begin.
Okay. Hello, my name is Dr. Memona, and I'm one of the surgical trainee over here. May I confirm your name and age?
Yes, I'm Samantha. I'm 53 years old.
Okay, nice to see you, Samantha. So please tell me, how can I help you today?
Oh, doctor, actually, I've had a severe headache recently, and that's why my husband brought me here.
I'm so sorry to hear that. Miss Samantha, today I have been asked to take a history regarding your medical condition. And for that reason, I need to ask few questions, if you don't mind. Is that okay with you?
Yes, doctor.
Okay, do you have any pain at the moment?
No, actually, they gave me some painkillers.
Okay, that's nice. So can we start our history?
Yes, sure.
So can you please tell me a little bit about your complaint?
Yes, actually, I was at home. I was doing my cooking and all the stuff, and suddenly there was severe headache, so I fainted. And when I woke up, I was here in the hospital.
Oh, I'm so sorry, Miss Samantha. So in which region of your head has a more pain? Can you point out the region of your head?
Actually, doctor, it's all over. There is no specific region.
Okay. So it goes to anywhere to your neck or any shoulder region?
No.
When did you first had this pain? Like as you said, before this episode, did you had previous episodes as well?
Yes, doctor. Previously, just 15 days back, I also had such kind of pain. It was very
Okay.
severe.
Okay, I'm so sorry to hear that. So, Miss Samantha, does it comes and goes, or it stays all the time there?
It comes and goes actually. This was
Okay.
just. Yes.
And what make the pain more worse, and how you relieved it?
Actually, that time also I was brought to the hospital and I was given certain painkillers, injections. Today I
Okay.
fainted. It was very severe.
Okay. So, how you describe your pain? Is it like stabbing pain or any cramping pain? How will you describe it?
Yes, it's a very severe stabbing pain, doctor.
Okay, and how it affecting your life?
Actually, doctor, I was doing my normal work after they gave me some painkillers. But this time, this attack was very severe. So, yes,
Okay, so if I tell you to rate it from 1 to 10, how will you rate it?
yes, it was almost 9, doctor.
Okay, 15, you said like one episode you had 15 days ago. In between of 15 days, did you had any episodes of headache?
No, it was just mild discomfort, no headache as such.
Okay, do you have any rashes over your body?
No, doctor.
And what about the like fever or any vomiting?
No, doctor.
Okay, and do you have any stiffness over your neck?
No,
Did you had any like history of trauma recently, like head trauma, any history of the fall?
no, doctor.
Okay, Ms. Samantha, can you please tell me about your weight? Did you lost any unintentional weight loss?
No, doctor.
How about your appetite?
It's good. It's normal.
Okay, do you have any kind of weakness in your body, like any arm or like lower limb?
No, doctor.
Okay, during this headache, do you lost your consciousness?
Yes, doctor. I fainted actually.
And for how long?
I think it must have been almost half hour because when I woke up, I was here in the hospital.
Okay, this was with both times, right?
No, it was only this second time.
Okay, do you have any visual problems, like do you see double vision or something like that?
No, doctor.
Okay, Miss Samantha, if you don't mind, can we talk about your personal history?
Yes, sure.
Okay, apart from this medical condition, do you visit your GP for any other medical conditions?
Yes, doctor. Actually, I have this high BP.
Okay, and what are you taking for that?
The name of the drug, I don't remember the dose, but some medication to lower BP is given.
Okay, so what about the surgeries? Did you had any previous surgery?
No, doctor.
Any allergies?
No, doctor.
Okay, what you do for living, Miss Samantha, if you don't mind?
Yes, I'm a teacher.
Okay, that's nice. So, do you smoke?
No,
What about alcohol intake?
no.
Can you
Okay.
summarize your history, please?
Okay. Today, Miss Samantha, a 53-year-old, presented with her husband with the episode of headache, severe headache, and it was sudden in onset. One episode, 15 days back, one episode was already noticed, for which she took some analgesic, and it was not associated with fever, neck stiffness, or diplopia, and the pain was 7 in by grade and throbbing in nature. And
Okay.
she was a teacher by profession, and she's hypertensive, and no surgical, and yes, and she has a
Okay.
healthy lifestyle. So
So what
on
is
the
your differential diagnosis?
so my on the basis of the history, my provisional diagnosis is subarachnoid hemorrhage,
Okay.
and it might be of the other differentials are meningitis, encephalitis, or any brain tumor.
Okay. So how would you confirm your diagnosis? What investigations would you ask for?
We will go with the blood investigations, in which we will do some blood CP, serum electrolytes, and BSR, and LFTs, RFTs, and after that we will go further of the CT scan of the brain with IV contrast, or possible then we will go with the MRI of the with IV contrast, and we will do LP, and we will send for the culture and sensitivity.
What are the treatment alternatives or options that you can offer this patient?
I will refer this patient to neurosurgery, and I will discuss with a multidisciplinary team, and we will relieve the pain initially, and we will give some IV antibiotics, IV fluid, and oral nimodipine, and yes, and surgically. Yes, sorry.
Yes, surgically.
Okay, if surgical, if the patient is not stabilized by medical treatment, then we will go further of the craniotomy through Burr technique.
Okay. Right. Thank you. Can you give feedback first?
Yes, ma'am. Ma'am, it was very good history. She covered all the points.
Okay. Yes.
Uh, yes, only thing, the pain history could have been more organized. Like
Yes.
yes, and she also would have asked if when I said hypertension, history of hypertension, then she
Yes.
could have asked for how many days I'm having this problem, for
Yes.
how many years, and
Okay.
since how many days I'm on medication, and
Yes.
also for ma'am, exacerbating and relieving factors.
Yes.
That's all, ma'am. Yes,
She
thank you.
asked about the history of trauma, but then when you were explaining the presenting complaint, and you told that you became unconscious. She did not ask about the history of vomiting, history of vomiting, or any history of appetite or history of weight loss to rule out any tumor. What else? Yeah. Okay. Another
Dr.
thing, when
Tanvi,
she was summarizing, when she was summarizing for me, she forgot to tell that if time would have allowed, the most
Yes.
important in this one was the family history and patient's associated medical condition, that patient has a polycystic kidney disease. So, and one aunt has had berry aneurysm. So that she forgot to tell, and even she forgot to tell the eyes and the systemic review. And in the beginning, I felt that she took the consent twice. You can correct me if you want. Yes, Dr. Burhan, I'm sorry. Yes.
Dr. Tanvi, thank you very much for the opportunity. Ma'am, I don't remember the name. She presented it very well, but one thing was missing that I would like to point out. She did not mention ICEI. Was that necessary in this particular patient? Or
She did not mention what? I can hardly hear you.
ICE, ideas, concern, and
Yes, yes, yes. I did mention eyes. Yes, she didn't mention that. Yes. It was very important.
Okay. Okay, because in the key notes, okay, in the notes there is no mention of eyes in this particular history, so I thought maybe we should omit it because it's not written there.
No, you have to ask in every history station. And then you have to, like systemic reviews given at the end, but then you have to cover it. And once she was summarizing as well, then she also has to mention things. Yes, all this. And the family
All right.
history and
Thank you.
the, yeah. Yes. Good. And here is your question. Right. Right. So if you have read and understood, considering it's surgical and optimization, kindly tell me what are you looking at?
Ma'am, these are the medial surfaces of the right and the left lung.
Yes. Okay. If we come to the left-hand side picture, can you please identify what is this 3?
Yes, ma'am. That structure is the groove for the azygous vein in the right lung, ma'am.
Okay. If you can identify 10 over here, please.
That is the horizontal fissure dividing the upper and the middle lobe.
Okay. Right. If you can identify 7.
That is the groove for the superior vena cava.
8.
That is the tracheal and the esophageal area where the impress on the lung.
All right. Can you please tell me the structures which are present in the what is this called?
Hilum of the lung.
Hilum of the lung, sorry.
Yes, ma'am. So the anteriorly there are the structure one, that is the primary. Sorry, posteriorly the structure one, that is the primary bronchus. The structure two is the pulmonary artery, and the structure 9 is the pulmonary vein, which is anteriorly.
The right pulmonary vein. Okay, right. All right. Can you identify the structures on the right-hand side image? What is 3,
Yes.
please?
That is the groove for the aorta
Yes.
in the left lung.
And what is this 4?
That is the impression of the first strip.
And
Groove for
5,
the first.
5, please. 5 is here.
I'll come back to that later.
Okay. 1 and 2 over here. These are the 2 2s and these are the 1s, if you can identify this. And this
Yes,
is
ma'am.
6 and then 7 and 8. If you can tell me all these, please.
Yes, ma'am. One is the primary bronchus
Yes.
of the left lung, and 6 are the pulmonary veins, and number 2 are the pulmonary artery of the left side.
And 8?
8 is the pulmonary ligament.
What is pulmonary ligament?
Pulmonary ligament is a pleural fold that attaches to the mediastinal surface of the lung and the pericardium. It allows the expansion of the pulmonary veins during increased venous return.
All right. Can you please tell me the surface anatomy of the lungs?
Yes, ma'am. The apex of the lung is the surface anatomy for the apex of the lung is a curved line joined from the sternoclavicular joint to the point at the junction of the middle third and the intermedial half of the clavicle, 3 centimeter above this point.
Yes.
And then the pleura comes down and meets the pleura of the opposite side at the sternal angle. Then anteriorly, sorry, the lungs we are talking about. Then anteriorly, the lungs extend from the suprasternal notch to the Ziphi sternum.
Yes.
And on the right side, inferior border is the 6th midclavicular line, line joining the 6th rib in the midclavicular line, 8th rib in the mid-axillary line, and the 10th rib along the vertical column.
Yes.
On the
And
right
posteriorly?
side, yes, ma'am. Posteriorly, it is the transverse process of the C7 and T10 is the posterior part.
Can you tell me the surface marking or the location of the hilum? Hilum of the lung?
So hilum is present in front of the T5, T6, and T7 vertebrae.
Yes. Can you tell me how many bronchopulmonary segments there are in each lung?
When there are 10 bronchopulmonary segments in each lung.
Can you tell me the nerve supply of the lungs?
Yes. The lungs are supplied by the pulmonary anterior and posterior pulmonary plexus by the vagus and the phrenic nerves, ma'am.
Okay. Can you please tell me which are the nerves which are related to the lungs, anteriorly and the posteriorly? So the relations of the lungs with the nerves.
Yes, ma'am. The phrenic nerve passes anteriorly to the hilum or the root of the lung,
Yes.
and to the posterior side there is the vagus nerve.
All right.
And
Does
the
it by any
sympathetic
chance? Yes, by any chance it comes in contact with sympathetic chain?
Yes, ma'am. The sympathetic chain is there in the posterior.
Okay. Would you be able to identify how many? How many lobes of each there are in each lungs? If you can tell me.
Yes, ma'am. So in the right lung there are 3 lobes: the upper,
Okay.
middle, and the lower lobe.
Which are
And the
divided
left
by how
Yes,
many
ma'am.
fishes?
So the upper and the lower lobe are divided by the oblique fissure,
Yes.
and the upper and the middle lobe are divided by the horizontal fissure.
Okay. And can you please
And-
tell me all the structures which pass through the hilum of the lung?
Yes, ma'am.
Broadly.
So the pulmonary artery and the pulmonary vein pass
Yes.
anteriorly. the main bronchus is posterior. Then there are the bronchial arteries and the veins, the autonomic nerves, and the lymph nodes.
All right, good. Okay, can you please identify, would you be able to identify these labeled structures in 1, 2, 3,
Yes.
and 4?
So the image one is the lateral surface of the right lung, and image 2 is the lateral surface of the left lung. The image 3 is the medial surface of the right lung, and image 4 is the medial surface of the left lung.
Okay, can
And
you
the
please?
structures,
Yes. Yes, please.
this one. So the structures, the structure 9 is the horizontal fissure of the right lung. The structure 7 is the oblique fissure, and structure 10 is the middle lobe. Structure 8 is again the horizontal oblique fissure of the left lung. And in the image 3,
Yes,
the structure
1, 2, 3.
A is, yes, 1, 2, 3. So 3 is the pulmonary vein. 3 is the pulmonary vein. Yes, 1 is the pulmonary artery, and 2 is the bronchus.
Okay, can you please
And
tell me if a central line is inserted, why a patient presents or the chest tube is inserted, why the patient becomes bradycardic?
there is irritation of the vagus nerve. That is why
Very
there is
good.
bradycardia.
Okay, can you please tell me the location where chest tube should be inserted?
So there is a safety triangle for the insertion of chest tube. So the triangle is formed by the posterior border of the pectoralis muscle, the anterior border of the lactis, and the anterior border, the mid axillary line, and a line joining the drawn from the nipple laterally.
Okay, can you please tell me the course of a clot which passes from the deep vein of the calf to the pulmonary artery?
Yes, ma'am. So the blood clot will travel through the popliteal vein to the femoral vein. From
Yes.
the femoral vein, it will go to the external iliac. From the external iliac vein, it will go to the common iliac.
Yes.
From a common iliac, it will reach the IVC. From IVC, it will reach the right atrium. Then through the tricuspid wall to the right ventricle, and from the right ventricle, it can reach the pulmonary artery.
Yes. Good. Thank you. And here is your question. Right. So if you have read and understood, considering this clinical examination station, kindly begin.
Okay. Good evening, sir. I'll come into the station, I'll wash my hands and introduce myself to the patient. Good evening. I'm Abbas. I'm a candidate in this exam. I've been asked to examine you. Can I confirm your name and age, please?
Yes, I'm Tom, 19 years old. Yes, continue.
Okay, Tom. Tom, so I'll be having a look at both ankles, and then it will involve me giving you a few instructions, and then I'll touch. It will involve me having a look, and then I'll feel, and then we may together perform a few movements on your ankle if that's okay by you.
Yes.
And then some special tests too. Okay, Tom. I would need you to roll up your trousers up to over your knees so that we can have a very good clear view of your ankle and then your knees, if that's fine by you. All right,
Okay,
then Tom.
continue. What would be the position?
All
of
right,
the
then.
patient?
Yeah, he'll be sitting at the edge of the bed,
Yes.
with his legs
continue.
swinging on the bed. Yeah. Okay, Tom. Before we start the full examination, I would want to you to walk for me, if it's okay. I'll put my hand in front of you and back to prevent you from falling down. So you'll be protected. Okay, I noticed Tom is walking with an antalgic gait, and it's quite painful. So Tom, there's no problem. You can just have a seat, so that we can do a full examination. I would be looking at this point. I would inspect his ankle, both the left and the right, from the front and then from the side. And then before I look at it from the back, I'll take his permission. I would have a quick inspection of the ankle, looking for scars, swelling. I would see swelling on the right ankle. I would also look for discoloration of the skin. I would look for a walking aid around Tom, and then I would also look for any deformity or abnormal positioning of the ankle joint. And then I would also look for presence of scars. Tom, I would want to have a feel of your ankle now. I'll start from your left ankle. I don't know if you can. Are you feeling any pain in your ankle at this point?
No, continue, please.
All right, thank you, Tom. So I would check for pain in the ankle. I'm sorry, warmth, differential warmth in the ankle. So temperature. I'll put my hand in the normal, just above the ankle, normal side, and then I'll check the ankle on the I'll palpate the feel back of my hand on the ankle, and then feel normal again. After that, Tom, I'll be moving your I'll be touching around your ankle now. If at any point you feel pain, just let me know, okay? So I'll start from the left side, which is the normal side. Then I'll move to the at this point I'll be checking the medial and lateral malleoli. I'll check the tarsal bones. I'll also palpate the calcaneum, and then I'll palpate around the soft tissue around the ankle joint, including the Achilles tendon, for tenderness, and also to assess the integrity of the Achilles tendon. I'll start from the left and go to the right. I'll be palpating. There might be tendon. There will likely be tenderness while I'm palpating around Tom's right ankle joint. So sorry, Tom. I'll be very gentle. If at any point you feel you're uncomfortable, just let me know. I'll stop. Okay. All right, Tom. So now that we are done with examining and touching your ankle, I want to move your ankle. So at this point, I would start with active movement. So I'll tell Tom, can you press your ankle down as if you're pressing on a pedal? Okay. All right. Then can you lift your ankle up as if you're trying to push it towards your head? Yes. Okay, Tom. Can you turn your ankle to face outwards, as if you're trying to stand on the edge of your the lateral edge of your foot? Okay. Can you turn your ankle inwards as if you're trying to stand on the inner edge of your foot? Okay, great, Tom. You're doing great, Tom. If at any point you feel pain, please just let me know. Okay. All right. So, Tom, I would want to do the same on your ankle, if that's fine. All right, so I'll do the same for Tom's ankle. I'd also attempt to also move the mid-tarsal joint of Tom's foot on both sides. Okay, so then after this, I would then do the special tests. I'll start by doing the anterior drawers test. Tom, I want you to. I'll be putting my hand at the back of your foot, just at the cup of your foot. I'll cup my hand on your foot, and then I'll hold the lower part of your leg, if that's okay, so that I can move your leg. If at any point you feel pain, let me know. I'll start from the left side to see moving the ankle forwards while stabilizing the tibia, and then I'll also do it on the right side. Tom, okay, and then I'll do the talar tilt test, which will involve the same movement. Okay.
Can you summarize your examination now?
Yes.
Please?
If I had enough time to complete my examination, I would have also I'll complete the talar tilt test. Then I'll also do the Simmons test to assess for integrity of Tom's Achilles tendon.
Anything else?
In some, I would also examine his knee joints and the metatarsal joints and do a full vascular examination of his limb.
Neurovascular, yes, of both limbs.
Yeah.
All right.
Neurovascular of both limbs. Yes, ma'am.
Yes. So can you please tell me your findings?
Thank you. Yes, ma'am. In summary, to summarize my findings, I've examined Tom. He's a 19-year-old basketball player who presented with some swelling and pain in his right ankle. On examination, he had an antalgic gait with tenderness around the right ankle, with swelling and positive talar tilt test in neutral position, indicating a central talofibular ligament injury. Okay, and then the anterior drawers test was negative, and Simmons test, if I had performed it, would be negative. Likely.
So what are your main differential diagnosis?
My differential diagnosis is ankle sprain, likely a central talofibular ligament injury. It could also be a deltoid ligament injury or a anterior talofibular ligament injury. It can also be a fracture of the tibiofibular ankle joint, fracture of the ankle joint, which could be a tibiofibular fracture. Or, then it can also be.
Would you confirm your diagnosis?
To confirm my diagnosis, I would want to do X-ray of the ankle joint, which is to do anterior posterior view and mortise view of the joint, and I also want to do an MRI of the ankle joint. If
what are the treatment alternatives that can be offered to the patient?
Yes, ma'am. I would commence him on elevate the foot. I would give you analgesics. I would place him on non-weight bearing crutches and put a below ankle, a back slab of the ankle for him to rest the ankle. I would, that's non-operative options. Operative options will include possibility of open reduction and internal fixation if there's associated fracture. I may also want to, I may also want to give do an arthroscopic repair of the injury.
All right. Yes, thank you. Right, so according to me, yes, you started off well, but then somehow during palpation, you slowed down. You were taking too much time to comprehend and express. Plus, when you were doing, after doing temperature, when you were checking for tenderness, you forgot to test, do the squeeze test, and you forgot to take the pulses. You took too much time, like doing active and passive movements, okay, but then you did special test, only one you had begun, but then yeah.
Yes, ma'am.
So my one single request would be that to practice talking, like if you'll take too much time in expressing what you want to say, this will take up the whole time and then you won't be able to complete your examination. It was simple and that could have been completed within the given time.
Yes, ma'am.
And here is your question. Right. So if you have read and understood considering this critical care scenario, kindly please tell me how would you manage this patient?
I would manage this patient according to ATLS protocol.
Yes.
First, I would see the patency of the airway. As this patient is a case of burn, so there are highly chance of inhalation injury. So I would rule out if there is any edema and the obstruction of the airway. So I would go for the endotracheal intubation. After that, clearance of the airway, I would make sure for the breathing. Then breathing, I would say I would see the adequate ventilation of the patient. Uh, if Because this is a burn patient, so there are high chances of tracheal and pulmonary burns. So it affects the gaseous exchange and the chances of compromise of ventilation. And then after that, I will make sure of circulation. So in circulation, I will do the IV cannulation, two large bore IV cannulation at the antecubital fossa, and I would start at the fluid challenge, that is a crystallite solution,
Yes.
and then I will
How
do the
would you make
disability.
sure you are giving adequate fluid to the patient?
First of all, ma'am, I would give the bolus to the patient at the 500 ml of crystallite solution
Yes.
for 20 minutes, and I will check the response of the patient by looking at the capillary refill time and by looking at the urine output of the patient. It must be 0.5 to 1 ml of
Yes. Is it me or Dr. Saddam's voice has gone?
Yes, we can hear you, ma'am.
Yes, I thought it's me. Kindly please tell me, if you don't get to manage this patient adequately, what are the complications that you should be careful about or you should look out for?
In this case is severe burn, so there are highly chances of hypovolemic shock. Patient might go into the sepsis, or patient might have a renal failure or ARDS, and
Okay.
patient might have a electrolyte disturbance as well.
Yes,
These are the
sepsis, renal
complications.
failure, etc. All right. Can you please tell me, considering the burns of this patient, how would you categorize it? Are they superficial burns or are they deep burns? And what is the percentage of burn patient has?
Percentage of burn can be assessed by the Velas rule of 9. And the patient is the difficulty of breathing, so it is a deep breath.
Can you tell me what are the ways by which you can assess the extent of burn?
Total surface area
Extent and depth. Yes. Yes.
and depth depend on the partial thickness and deep thickness burn.
Okay. You said patient can even go into adult respiratory distress syndrome. Can you explain what is it? What is it categorized of?
If you're asking the definition, it's the diffuse inflammatory form of lung injury that characterized by the hypoxemia and decreased lung complex and the ratio of partial pressure of oxygen FiO2 also decreased in this condition. That overall leads to the decreased lung complex and patient might have difficulty of breathing.
Yes. Anything else? How would you differentiate between progressive and refractive hypoxemia? Okay, can you please tell me how would this ARDS affects the VQ mismatch?
Yes, ma'am. Basically, it is the two phases. One is the acute phase, another one is the late reparative phase. In acute phase, when there is a burn, there is highly chances of destruction of capillary endothelium, and by which the protein rich fluids is extravasated from the interstitial edema, and that causes the accumulation of neutrophils that release the cytokines. And and then that cytokines can cause the destruction of alveolar membrane and fluid is accumulated and it can cause the ventilation perfusion mismatch.
Okay,
Later on,
good. Right. Can you please tell me where would you manage this patient?
I would like to manage this patient in the burn unit.
Burn unit. Okay. What is the criteria for managing patients in the burn unit?
There are multiple criteria. One is the one patient requiring the IV fluids. Another one, the total body surface area burn. If it is greater than 10% in adult and 15% TBSA in the children, patient is unable to maintain the saturation. Patient has a severe pain. So these are the 4 to 5 criteria of admission in the burn unit.
Okay. What investigations would you ask for this patient?
Investigation, I would like to do full blood count and the urine electrolytes, serum albumin, and then ABGs.
And
VQMS,
chest X-ray.
yes.
Just suppose you have done the chest X-ray and this is something you got. So can you please help me read it out?
This is the X-ray chest PAU. They're showing the laterally. The loss of costophernic and cardiophernic angle as well, and there is also the increased shadow of heart. So this is highly likely the diagnosis of ARDS.
Okay. How would you take care of the nutritional status of the patient?
In this case, the internal nutrition is better than parental nutrition. So I would like to give the high protein diet and carbohydrate diet because there is chances of fluid loss and protein loss in this case as well.
Okay. Considering a patient has ARDS, how would that affect the compliance of the lungs?
Decrease the ventilation perfusion and
Yes. It will decrease the
because
lung
of the
compliance. as well.
lung compliance. Yes.
Okay. Can you please tell me what is Berlin's criteria?
Yes, criteria actually define the ARDS on the basis
Yes.
of stages either the mild, moderate, or severe.
Yes.
It consists of 3 grades. So in mild, the PaO2 and F5 ratio is 200 to 300 in mild cases, while in the moderate cases it's 100 to 200, while in the severe cases less than 100. The mortality rate for mild 27%, and for the moderate almost 35%. For the severe it is more than 45%.
Okay, good. Thank you. Right. Okay. Right. So if you have read and understood, considering the communication skills station, kindly begin.
Hello, I'm Fozia, one of the surgical residents. Are you Tom's mom?
Yes, I am.
I'm here to talk to you regarding Tom's health. Can you please tell me what how far you know regarding his health at present?
I know nothing, doctor. I just got a call in my office that my child was taken to the hospital from the swing because he fell off the swing. I don't know what's going on. I'm very anxious. I don't know where he is. I just want to meet him right away.
I can understand your concern, ma'am. Would you like to have a seat?
Yeah, that's okay. But I really want to see Tom because I'm really anxious how he's being. If he's in the hospital, nobody called me earlier. I'm very anxious.
I'm sorry, we could not inform. You have not been informed by us, but I'm here to explain you. And basically, you're right. Tom had a fall while playing in the swing in the school, and when he was brought here, he was unconsciousness. He was unconscious, and he had injured himself badly. And it was an emergency, and we had to run him to the OT before we could get to talk to you. I'm sorry, he was shifted to OT or operation theater before you haven't seen him.
But how can you take him to the OT, doctor? Won't you need a consent from me? I'm his mother. I'm his biological mother. How is that possible? I really want to see him right now.
I'm sorry, I understand your concerns and your rights, but his biological father was with him, and we have taken consent from him. And unfortunately, it was a bad condition. He was in bad condition. He was unconscious, and the scan showed he was bleeding from inside. So we took consent from his biological father, and in a good sense, for the good of your child, we want him to be in good health, and it was in a good faith to help him, because if we could have waited for you, we would have wasted more time.
Okay, I understand your part, but I seriously consider not trusting his father because I'm very sure he's drunk even now. I don't think you should let my child meet his father anymore.
I understand your concern. Has anything like this happened before?
Yeah, the thing is, I'm separated from my ex-husband now, and he's almost always drunk. And I don't want my child to see him any further.
I'm glad you brought the issue up here. And in these cases, our first priority is the child's protection and safety. And I will definitely pass the information to my to child protection services at our hospital, and who will look into the matter and help in keeping your child safe. Would that be fine?
Yes, doctor, that's okay. Can you tell me more about Tom? How is his condition now? Is it really
When he
dangerous?
Okay, I'm here to help you anytime. When Tom came here, he had lost unconscious. He had lost his consciousness, and we ran a test which showed that he was bleeding inside. So and it was his life was at risk. So we had to be fast, and the scan showed he has injured an organ in her body, and he was bleeding. So we had to shift him to the theater to repair it. He's in good and well experienced hands, and we hope he does well.
What do you mean by repair? Like, is his organ going to be normal? Will he be normal for the
It
rest of
will.
his life, or is he going to suffer anything?
This will depend upon how bad it injured. Sometimes we can just repair it by giving some sutures, and sometimes it's badly affected or injured. In that cases, we might
No, I
remove the
just wanted to
spleen.
ask doctor that what does this organ do? Like, how does this affect his life after the operation?
The organ plays an important role in body's defense mechanism. So your child, if we had to remove the spleen to save your child's life, your child will have a risk to get some infections, and after the surgery he will have to get vaccines for some disease which he might be more susceptible. and we will keep him on antibiotic prophylaxis, and he will have a normal life, but he has to take some preventions and some vaccines to avoid those infections which might affect his life badly.
All right, doctor. That's really concerning. And for how much time does it has to take the antibiotics? And when can we discharge him? When can I take him home?
He has to take the antibiotics for lifelong, and vaccines have to
Lifelong.
be
That is really hard to take that medication lifelong.
we will discuss with the medicine people also, medicine registrars, but these are guidelines which we follow, and this is what we do here for these things.
And what about his discharge? Do you have any idea when can I take him back home?
Our first priority is Tom's medical care, and we hope he does well. And after the operation is over, and when he recovers well, we will not discharge him until we have examined him, and we will make sure that he is registered under a GP who is informed that there may be concerns regarding Tom.
Okay. Thank you, doctor.
Do you have any other questions? Do you want me to answer your any queries?
No, doctor. I just want to meet my son. I'm just hoping he comes back early from operation theater.
As soon as I hear anything from the theater staff, I'll let you know. So your child had fall while playing on the swing in the school, and when he came here, we ran a scan which showed he has injured his spleen. Currently, he's having an operation for the same, and we hope he does well. In case you have any queries, you can contact the nurse on the counter. She will get back to me, and I'll be here. Would that be fine?
Yes, doctor. Thank you.
Thank you. Thank you for your time. Thank you.
Okay, just a few seconds left. 10 seconds. Okay, can you begin and give feedback to Dr. Fuzan?
Yes, ma'am. I think she covered. I think she did very well about the communication. Only some questions like the splenic function, she could have told me that without me asking her about that, so that the mother knows more about the situation.
Yeah.
And also I think that is it, ma'am. Rest of the things she covered pretty much or everything.
It was better than yesterday.
Just one or two questions where she could have explained.
Yes.
Hello.
Explain what
she could have explained herself rather than me asking her.
Yeah.
Excuse me, ma'am. I want to ask one question.
Yes.
Like in this stem, there is one line that the mother is not allowing you to go ahead with surgery.
Yes.
In this conversation, I couldn't make out that the mother was convinced that the child should undergo surgery. This is one point. Another point is that under the British law, if the child is in life-threatening condition, is it mandatory to take permission from mother, or the surgeon can do it on his own? Because
that's why they didn't listen to her. But first, like a child needs a permission from biological parents. But since this was like life-saving procedure, so they didn't wait for her. She thinks that it was like consent was given by the biological father, and that's why they're doing it. In fact, it was not even that.
But we can straight away say that every minute counts in this situation, and the doctor did the best to save the child in this situation. Yeah,
is trying to do the best to save your child. Yes, we can definitely. Yes, Dr. Abbas.
Thank you, ma'am. Thank you very much, Dr. Fosnas and Dr. Rohit. I think one more thing, your summary was good, and I like the fact you summarized after the discussion. I just wanted to add a few to maybe that will help you. That before you summarize, I noticed after you finished discussing, you just started summarizing. Just to for Okay, you can just tell the patient that first to summarize what we've been discussing this past few minutes, so that I can confirm that I've gotten everything we've discussed clearly. I want you that this and this and this, and when you finish, is that okay? Do you have any other questions for me, or am I correct? Do you have any other questions for me? Then that's just my addition to your presentation. However, the other comments have been made. Well done, Dr. Foslas.
Good. Yes, Dr. Rohit, you raised hand.
No, nothing, ma'am, regarding the question that that she did not convince me it was an emergency. She did, because she said that if we had wasted time, it would have been life-threatening for my child. So that is why the mother was convinced.
Yeah. Right. Feedback from me, it was very good compared to yesterday, but then there were certain things like you were talking medical terminologies like prophylaxis. Yeah, you can say you can give medication so that it will prevent future infections instead of using the word prophylaxis. And then also you can, when mother asked you about the discharge and all that, so you could have explained post-operative complications or what you suspect or can occur. So that you could have added. Yeah. Itself, but then yeah, we'll do another one tomorrow, and it will become better definitely.
Thank you, ma'am.
The timer and to the question. Right. So if you have read and understood, considering it's surgical and optimization, kindly please tell me if you can identify what you're looking at to begin with.
Yes, ma'am. It is a xylogram
Okay.
showing the parotid gland and a Stenson duct.
What is the surface anatomy or the location of the parotid gland?
Yes, ma'am. The superior border, it is formed by a curved line joining the tragus and middle of the mastoid process. Posteriorly, from middle of the mastoid process to a point 2 centimeter below and behind angle of mandible. Anteriorly, from the tragus to the center of the posterior border of masseter, and from there to the point 2 centimeter below and behind angle of mandible.
Okay. Can you please tell me where exactly it has its upper end, anterior end, and the posterior border? You told me.
Yes,
Okay.
ma'am.
The surface anatomy of the gland itself.
Yes, ma'am. The gland, it lies just from the in the retromandibular groove usually, just from the tragus to the mastoid. From there, a point 2 centimeter below and behind the angle of the jaw.
What type of gland is the parotid gland? What type of secretions does it secrete?
Yes, ma'am. It is a mixed gland with predominantly serous secretions.
Yes. Yes. Okay. Can you please tell me if there is a swelling of the parotid region, What are the differential diagnoses that you'll consider?
Yes, ma'am. It can be infective due to parotitis or an abscess.
Yes.
It could be lymph node enlargement of the parotid region. It could be inflammatory due to sarcoidosis or mumps, or there could be an obstruction of the duct due to calculus within the gland or within the duct, or maybe obstruction of the duct from outside, or it can be a tumor, either benign or malignant.
Okay, can you tell me, please, the blood supply of the parotid gland?
Yes, ma'am. It is supplied by the branches from the external carotid artery. This is usually the superficial temporal and maxillary.
And the venous drainage is?
It is the retromandibular vein.
Okay, can you please tell me few structures which pass through the parotid gland?
Yes, ma'am. From superficial to deep, there are the facial vein and its terminal branches. Then there is retromandibular vein. There is external carotid artery dividing into external the superficial temporal and maxillary artery. Then
Yes.
there is auriculotemporal nerve and deep parotid lymph nodes.
Yes. Can you please tell me the nerve supply of the parotid gland?
Yes, ma'am. It is supplied by auriculotemporal nerve and by the branches from the OT ganglion.
OT ganglion. Okay. What type of ganglion is OT ganglion? What kind
It
of
is a
innervation?
parasympathetic ganglion.
Parasympathetic. Okay. Right. Can you tell me the course of it? How is?
Yes, ma'am.
Through which? Yes.
It starts from. Yes, ma'am. It starts from inferior salivatory nucleus through
Yes.
glossopharyngeal nerve.
Yes.
Then to the tympanic plexus.
Nerve too. Yes. And
From
then
there, yes, from there, from
lesser
the
petrosal
lesser
nerve.
petrosal nerve
And then lesser
and to the
petrosal
OT
nerve.
ganglion. Then
Yes.
from there to auriculotemporal nerve, and then to the
Nerve.
parotid.
Yes. Good. Can you tell me the lymphatic drainage of the parotid gland, please?
Yes, ma'am. It goes to superficial and deep parotid lymph nodes, which they thereby drain to the superficial and deep cervical group of lymph nodes.
Okay. Can you please tell me what are the type of tumors which can occur in parotid gland?
Yes, ma'am. There can be benign tumors such as pleomorphic adenoma and
Yes.
Warthin's tumor.
Yes.
And malignant tumors may be adenoid cystic carcinoma and mucoepidermal tumor.
Okay. Can you tell me if there is any syndrome which can be associated or can be found with the surgery of parotid glands?
Yes, ma'am. There is a Fraze syndrome.
Yes. What are the
Uh,
characteristics of the Fraze syndrome?
It is characterized by gustatory sweating. Whenever person smells or thinks or eats food,
Yes.
there would be sweating around the temporal region.
Yes. And it's a result of injury of what?
Yes, ma'am. It's a result of injury to branches of auriculotemporal nerve, which is parasympathetic nerve, due to abnormal connection between the sympathetic and parasympathetic fibers.
Okay, can you please tell me where the parotid duct opens? If you can tell me the surface anatomy of it.
Yes, ma'am. It opens just opposite to the second molar tooth in the mouth. The surface anatomy is it lies at the middle 1/3 of the line joining from the intertracheal notch to the philtrum.
Okay. Can you please tell me on the undersurface of the mandible, there are also location of certain other glands. Can you name them, please? And how many of them are there?
Yes, ma'am.
The
There
floor
are
of
lingual
the-
glands.
Yes.
Yes, ma'am. Lingual glands and submandibular glands.
Yes. How many submandibular glands are there?
There are 2 submandibular glands.
Yes. can you please tell me what type of secretions is there or is secreted by the submandibular gland?
It is predominantly mucus secretion.
Mucus and serosis mix. Okay, can you please tell me the surface anatomy of the submandibular duct, where it opens?
Yes, ma'am. It opens just lateral to the frenulum of the tongue.
Yes. In the floor of the mouth. Okay. Can you please mention few nerves which can be injured as a result of submandibular surgery?
Yes, ma'am. It can be the marginal mandibular branch of facial nerve, lingual
Yes.
nerve, and the hypoglossal nerve.
Yes. Yes. Right. How would the patient present if there is injury to the marginal mandibular nerve?
Yes.
A branch of which nerve?
It is a branch of facial nerve, so it supplies the angle of mouth. When patient is asked to smile, there would be crooked smile
Yes.
in this injury.
What is the mode of injury? How this injury occurs or takes place?
Yes, it can occur due to trauma or during surgery. Iatrogenic.
Heterogenic.
Mandibular.
Tell me the location, because once you're doing the surgery for submandibular gland, so there is a certain point where you have to make the incision.
Yes,
4
ma'am.
centimeter. Yes.
It is 2 centimeter below the lower inferior margin of the mandible.
4 centimeter. Yes. So if you make it above, higher, then it can cause injury. Okay. In this image, can you see any abnormality? Is there any abnormality? Or what is it showing?
Sorry, ma'am, I don't find any abnormality. Yes, maybe there is a calculus just at the tip of the. Yes, ma'am.
Yes. Good. Here is your question. Right. So if you have read and understood, considering the surgical pathology patient, kindly tell me what is your provisional diagnosis for this patient?
Considering the history and the CT finding, my provisional diagnosis will be pancreatic tumor, ma'am.
Okay. Pancreatic tumor. Any other differential diagnosis that you'll consider?
I would also like to consider pancreatic pseudocyst, and if I consider the symptoms, then I can also keep as a peptic ulcer disease.
Okay. What are the conditions which present as hyper-enhancing lesions on CT scan?
It could be pancreatic tumor. It could be collection around the pancreas. Could be
What are the conditions
cyst.
which lead to collections around the pancreas?
Due to acute pancreatitis, due to pancreatitis, and because of the obstruction of the duct.
Okay. How pancreatic cysts are formed?
Due to the persistent inflammation and infection, inflammation of the pancreas, there is excessive fluid collection, which can eventually form in the, collect in the form of a cyst, ma'am.
If a patient presents or patient has chronic formation of, or the chronic condition in which patient has this formation of pancreatic cyst, so what will be the cardinal features with which patient will present?
In chronic pancreatic cyst, a patient can present with the epigastric discomfort, early satiety, epigastric mass or lump. Our patient can also present with vomiting, nausea, and epigastric discomfort or pain.
Okay, here the patient had the history of hyperparathyroidism before, which became gradually worse and presented it like this. So if you can think of any other condition which can cover this, these symptoms of the patient, what could that be?
Yeah, considering the history of hyperparathyroidism, I would also like to consider parathyroid hyperplasia. And here, since I'm considering pancreatic tumor, and it could come under the syndrome like known as the MEN syndrome, multiple endocrine neoplasia.
Can you define the term hyperplasia, please?
Yeah, hyperplasia, it is the condition where there is increase in number of the cells, leading in the increase in number of the size of the tissue or the organ.
Yes, but then your definition is not correct. Increase in the number of cells in response to its stimuli.
In response to a certain stimulus.
Yes. So how many parathyroid glands normally there are in a human being?
We have 4 parathyroid glands, ma'am.
So when there is hyperparathyroidism, so how many normally get affected? Is it likely
Usually
that
all
only,
the 4,
yes,
ma'am.
all 4? Okay. What would be the microscopic picture if a patient has hyperparathyroidism, hyperplasia of the parathyroid gland?
Yeah, usually the classical feature is the chief cell hyperplasia, which may involve in the nodular pattern or the multinodular pattern or diffuse pattern. We can also find the pattern of water clear cell hyperplasia, and in certain cases we can also find the islands of oxyphil cells now.
Okay. Right. Can you please tell me how do you intend to manage this patient now?
Yeah, considering the symptom and the findings, I would like to initially manage this patient according to the CRISP protocol, ABCDE, considering the ABCDE approach. Here I would like to give I would like to manage the pain of the patient, epigastric pain, according to the WHO pain ladder. I'd also like to give the patient nil per mouth and manage the nutrition, start total parenteral nutrition, and also consider early institution of oral enteral nutrition. Then I'll also give the patient IV fluids, and which is IV fluids, and also PPI and some somatostatin analogs. And then after confirming the diagnosis, I will discuss with the multidisciplinary team, and then manage. And then if I'm considering if it is tumor after the diagnosis, then I will manage according to the stage. Usually, I will consider surgical resection.
Okay, can you please tell me, you said because of hyperparathyroidism, you'll consider this to be as Men syndrome. What is the
Man syndrome.
Yes, what is the characteristic of this syndrome?
Yeah, multiple endocrine neoplasia. We have MEN1 and MEN2. In the MEN1, we have the usually the three findings. We have the pituitary adenoma.
Yes.
We have the parathyroid hyperplasia, and then the pancreatic tumor.
Yes, those two you already told me. So pituitary adenoma was the one I was after. So can you tell me how would you differentiate it from MEN2 syndrome?
In the MEN2, we have the parathyroid hyperplasia, and in 2A we have pheochromocytoma and the medullary thyroid cancer.
What
and
are the
in
genes
MEN2B
which are
we
involved? Yes, in MEN1 syndrome.
MEN1 the MEN1 gene is involved, and the MEN2 the red gene.
No, what are the genes? What are the three genes which causes the mutation in MEN1 syndrome? If you can tell me the name of the genes.
MEN1 gene.
Type 1, in type 1 there are three genes. If you can tell me the name of those three genes.
Type 1 menin gene, ma'am.
What is the mode of transmission of this condition?
Yeah, it is transmitted through autosomal dominant pattern, ma'am.
Yes. Right, it is like PTN and TSC2, and then there is another one.
DXS and ATRX, ma'am.
Yes, ATRX, yes. Yes. So that was
These are the of insulinoma, ma'am, or is it for the MEN1?
Yes, insulinoma. Yes, please. Right, so if you have read and understood considering this communication skills session, kindly begin.
Yeah, hello, good afternoon. My name is Abdul. I'm one of the surgical doctors. I've been asked to discuss with you the investigation we are about to arrange for you. Can I confirm your name and date of birth, please?
Yeah, my name is John, doctor. I'm 55 years old.
Oh, nice to meet you, John.
Nice to meet you, doctor.
Yeah, please, can you have a seat? Are you with somebody?
No, doctor, I'm alone. I just dropped to the hospital.
Okay, thank you. I want the nurse to be with us here. Is that okay with you?
Sorry?
I want the nurse to be with me here while I talk to you. Is that okay with you?
Yeah, sure, doctor. No problem.
Good. Can I ask you what you know about your condition and the test we are planning for you?
Yes, doctor. I had this difficulty in swallowing for the past 1 month, and I went to the GP and he referred me to the hospital. They did some tests, this was X-ray, and they said that somebody is going to talk to me about the result. And that's why I'm here.
Yeah. So sorry to hear that. Quite all right. I've seen the image. They show that you have some narrowing of your food pipe, like I've said. But the investigation we're planning to arrange for you is called the Osophagogashynoscopy. Have you heard that before?
No, doctor. What is that?
Okay, so osophagogashynoscopy is the form of investigation where we pass a camera, which is called the endoscope, through the mouth, then it goes to your food pipe, then goes to the stomach, and then the beginning of your intestine. This is so that we can, visualize what is happening, what is causing the obstruction that you're having in your food pipe. And this relays the image to a TV screen so we can see live what happens. And at the same time, we're able to, dilate the narrowed part of your food pipe. And you can also take some tissue samples if we find anything sinister in your food pipe.
Yeah, doctor, it sounds quite horrible. It must be quite painful.
Well, you won't feel pain because this will be done under some form of sedation, and we'll give you something for pain as well. So you won't feel pain during the procedure.
Okay, doctor. And what about the complications? Are there any complications of this procedure?
Yes, every procedure has got complications, but then this doesn't happen often because you'll be handled by specialists who are adequately trained and professionals in this field. One of the things that can happen is, of course, damage to your dentition while passing the instrument through your mouth. You can also have bleeding from the point where we take the tissue samples from.
Okay,
infection is also possible because we're introducing a foreign body into your food pipe. But the most dreadful complication, which doesn't happen often, is that the wall of your food pipe might be ruptured, might be punctured by the instrument, and that will warrant another surgery, for repair. But like I said, this doesn't happen because you will be handled by people who are experts in this field in our hospital.
Yeah, doctor, but is there any other investigations? I thought if this perforation occur, I might die, and that's quite horrible. Is there any other investigation that can replace this test?
Well, there are other investigations that we can do, but this test is the first line of investigation for us to do because it will tell us what's happening. We can even, give you some form of treatment during the procedure, dilate, your food pipe so that you start passing, your difficulty in swallowing, will resolve, and then it can guide us on further investigation you need. So it would be nice for us to start with this investigation. Now we graduate to other investigation to look at, whatever is happening.
Doctor, how much time it will take, the procedure itself?
Yeah, the procedure will just take a couple of hours, and you're able to go home the same day. And if you wake up, usually you gain consciousness within 2 hours or so. You should be able to go home, but then you won't be able to drive yourself, and you will need to come in with somebody that will drive you home, and you will not need to do because you'll be drowsy after the procedure. So it will be advisable that you have somebody, an adult with you, to escort you back home.
Okay, doctor. And what about my labs? Have you seen my labs? I would like to know something about my labs.
I don't have your lab results yet, but I'm going to have a look at them, and then I'll get back to you with the results. Is there anything else I can help you with? Do you understand everything I've said?
Yeah, doctor, I understand that.
Good. What are your expectations from this result or from this investigation? What do you think we're going to solve?
Yeah, doctor, I'm hopeful that I will go through without any harm, and probably I will get to some diagnosis. I'm very worried about my problem. Yeah.
Yeah, sure. Yeah. That's true. The investigation really will tell us, will guide us on what is happening about the diagnosis, and also will guide us on further investigation that we'll do to be able to, give you a more robust diagnosis and prognosis of whatever is happening. Just to recap what I've said, so that because you need to sign the document before you sign that, I just want to recap all I've said. So we'll be listing you on the waiting list we'll be listing you for the Osophagogashynoscopy, which is an investigation that involves passage of an endoscope, which is the camera through your mouth to the food pipe, then through your stomach and the first part of the intestine. This is to allow us to visualize the internal part of your food pipe and see what is causing the narrowing. And also to, we can see this, we'll be able to see this on the TV. Then also we can also dilate the narrowed part so that you can have some relief of, your symptoms of difficulty of swallowing. And as well, we can also take some biopsies. And I've told you complications that can come up with this procedure, although it's not common because you'll be handled by specialists. And you'll be able to go home the same day once you are awake. And you should ensure that you come in with an adult that will drive you back home because you won't be able to drive because you'll feel drowsy that day. So if you're fine, if you're happy and happy to go ahead with the procedure, yes, the document, I want you to put your name here, your signature and your date.
Yeah, sure, doctor.
Thank you very much.
30 seconds are still left.
30 seconds.
Yes.
Do you want some coffee?
Yeah, sure.
Okay. Let me get some coffee. I'll leave
Did
my
you-
number.
I have
I'll leave my number with the nurse so you can,
Yeah.
in case you remember anything, please feel free to call me or get the nurse to reach out to me. And I'll
Sure.
also give you some inpatient information leaflet which you can study at your own time, to understand better. It has some illustration that can tell you,
Very good.
better
Yes.
what we're trying to do. Yeah.
Good. You consumed your
Yeah.
last 30 seconds very well. Okay. Yes. Can you please first give the feedback?
Yeah, it was good, madam. 10 out of 10. There was nothing left, and he was very fluent and he was very confident.
Confidence there was definitely,
Yeah.
but did he miss anything or he told you everything very nicely?
Yeah, I
Because-
think it was all of things were there. Maybe one thing that I thought that maybe in the follow-up he needs to say that after the procedure, but that's something after the procedure, right? That you need to observe for any bleeding or any complication and come back to the hospital. But that's post-procedure, not right now.
No, but then the advice after procedure was supposed to be given, like what food to eat and how to keep yourself well. I don't think that he gave you that, did he? And in the beginning, like you were supposed to ask if smoking or drinking has caused you to have the cancer, or was it a cancer? These questions could have been asked.
But this is for the procedure, right? We are not there to take history. So if you are
No,
going to
but
go into
you're
that side,
asking question like, since I smoke and I drink, do you think that might have caused this narrowing of the food pipe? So you are not giving history, you are asking, like patient is asking. So these are the things that would be covered. So then that this 30 second would have been, and why I keep on salivating. So this is the patient who's asking.
this is one question I missed really. I could
Yeah.
not recall. Yeah.
So, and then what Dr. Abdul Razak said when you asked if there is any other method that you can offer me instead.
Yeah, he did not mention any method. Like I was hoping that he would say
Yes,
MRI or
he
CT
missed.
scan.
No.
Yeah, but he only said that I will go for because this is the best method and
Yes,
it will allow us to
but
sample.
then he should have said the other method that we could have advised that you have already done, because patient has done the barium barium swallow, and then the disadvantage he should have mentioned with this procedure was that we couldn't take the biopsy. Now that we are doing this procedure, we want to take a tissue. So I think he missed that part of conversation.
Yes.
Yeah, the risks he explained very well. And yes, right. Yeah, overall it was very good. Yes, very good. He began very confidently, which was nice. Yes, good. Thank you. But the room for improvement is always there. Good.
Yes.
Thank you.
Thank you very much.
Okay.
Yes, and here is your question. Right. So if you have read and understood, considering the communication space station, kindly begin.
Hello, I'm Dr. Mohammed, an exam theoretical candidate. And confirm your name, please.
My name is Andrew.
Name and
Nice
date.
to nice.
Yeah.
Okay,
Nice to meet you, Doctor.
nice to meet you.
Yeah.
I'm here to explain to you. I have been told that you want to leave the hospital.
Yes.
I just want to explain your case before you decide. Are you okay with that?
No, that's fine.
Okay. You have something we call it splenic hematoma, which is a collection of blood around your capsule of your spleen. Spleen is organ in the upper left side of your tummy. Okay.
Yeah.
And also you have noticed that your hemoglobin have been dropped by 2 grams. This give us clues that you might have internal bleeding. So this might put your life in danger.
Okay.
Okay.
But I feel fine.
Sorry?
I feel fine. I feel very fine. That's why I've decided. I told the nurse that I want to go home.
Okay.
Yes. Say that you understand. Patient's
So you
frustration, yes.
understand? Yes. So you will not leave the hospital?
Yes,
By
I want,
now?
to leave, I want to leave the hospital, but I feel fine and staying in the hospital is not palatable. You know, it's frustrating.
I understand that, but now we need to put you in the hospital. Just we need to observe you for a few days. We can't discharge you right now. I'm sorry for that.
You mean I can't go home?
Yes, we can go right now, but after a few days, we have to do some investigations, and then we might let you go.
Okay, my wife has cancer. You can't hold me. I need to go with her to the doctor. I don't understand.
I'm really sorry for your wife, but I understand that you right now we have to focus in your health, and if you have any deteriorating your health, your wife might be in danger also, as no one will look after for her. I can also arrange some social worker for your wife until you become well.
Well, thank you for that. But then there's this job interview I've been chasing for a while that just came through, and I need to be there as well for the interview.
Again, I understand that, but also you have to reconsider your own health. You can search for another job later. Sorry for that.
I don't know. It's been a while that I've been chasing this job, and I just got it now, and I just need to be there, you know, to attend my job interview.
I understand that, but you really need to reconsider your own health right now, as your life might be in danger, and you can find another job.
Well, like I told you earlier, doctor, I feel very fine. I'm okay. Look at me. I'm okay. I'm not in pain. I mean, I was in pain earlier, and I'm fine now. I can go home with anesthesia and all that. I've got some paracetamol at home. I need to be at the job interview. It took me a while to secure this interview. I need to be there. Sorry, I really need to be there.
I'm really so sorry for that.
Yeah.
But again, I understand that your concern, but I really can't charge you right now. We need to do some investigations, and also you need to observe you for a few days again.
Sorry, doctor, I can't stay in the hospital. I can't. I cannot stay.
Okay. If you want to leave, you have to sign a document for me stating that you understand what we have been through, and also stating that the adverse consequence, and also you have been advised to admit to the hospital.
That's no problem. I will sign the document.
Okay. Can you summarize for me what I have told you? That just to ensure that you have understood me correctly.
Yeah, you said that you want to keep me in the hospital. You want to keep me in the hospital. You said I can't go home because I have this. You said you call it spleen in my tummy. That's bled, and collection of blood, and my hemoglobin, or what you call it, has dropped. And you said my life might be a danger, but like I said, I feel very fine. And pretty much
Okay.
that's all you said. Yeah.
Okay. Before you leave, if you just want to advise you, if you have felt any dizzy or any non-bearable pain in your tummy, you have to come back to the hospital and the ER, and also ask them to contact me or the doctor in charge. Okay.
That's fine, doctor.
Okay. Now you have decided to leave, and you will sign a document for me. Just before we end that, I need to sum up what we have been through, okay? You have been diagnosed that you have splenic hematoma, and have been explained that you medically advised to stay at hospital, but you decided to leave, and also have advised you about the sign acceptance that if it happened to you, that you have to come back to the hospital.
Yes.
Okay.
Yeah, I understand that.
Do you have anything else you'd like to ask me?
No, nothing. I'll just like to
Okay.
sign the form now. And
I will leave my number with the nurse. Okay. If you have any question, don't hesitate to contact me. Okay.
no, that's fine, doctor.
Thank you for understanding.
Yeah, thank you for
Good.
thank you.
Still 20 seconds left. Nice ending. Yes. Very nice effort,
Thank you.
considering it was your first time. So when Bell will go, then we'll start with the feedback. 5 seconds. Yes. Right. Can you please give feedback first, Dr. Mohammed? Dr. Abdul Razak? Can you, yes, please?
Yes. I think Dr. Mohammed tried.
Yes.
Yeah, he really tried. He tried to cover most of the steps.
Yes.
But then there's need for some improvement as well. Yeah.
Yeah, definitely.
Yeah.
Yeah,
So,
but then how you felt when you were communicating with Dr. Mohammed, could you follow?
Yes.
Did you feel that a good conversation or communication is going on between you two?
Well, there's some feeling I had like he's telling me I cannot go home. You know,
medically, like, yes.
You know, you say you cannot go home. You know, the way he said it, I felt like, you know, you're trying to hold me against my wish. You know, I just felt like there's a way you should have said that, okay, that, you know, maybe even had it that medically it's not advised for us to allow you to go home. You know, you just said you cannot go home. So, you know, it sounded one kind. Then also the terminology, you know, you try to use layman terms most of the time, but there was this part that you said capsule. You know, it would be better to say the splenic covering.
Yeah.
Yeah, you did well. You know, when you're talking about the tummy, you said the abdomen, you said tummy. You know, but the splenic capsule, instead of saying capsule, just say splenic covering. Then I didn't see much. Yeah, I didn't see much empathy when I was talking about my job interview. and my wife has cancer.
Yes, empathy when you tell about wife having cancer, but not with the job interview. That doesn't have to.
Yeah, that's true. Yeah, we're empathy with the wife has cancer, but then when I said I have a job interview, you didn't really care. You just said I can fetch for another job. And that was not nice. That should be the first thing, that you can get another
Emotions
job.
You have to put in it. Yeah.
Because I felt like it took me a while. As I said, it took me a while to secure this job. And the next thing you said, you can find another job. You know. Then, well, with the wife, you tried by saying that you're going to get me a social worker. Then.
Yeah, that he explained.
Yeah, that was good. So, by and large, I think you tried.
Yes.
Just some few things, and also a lot of hesitation. There were a lot of hesitation.
It was the first time, yes.
Yeah.
Yes.
So.
Yes.
Yeah.
Good.
That's it.
Thank you.